want you to picture a job title for a second. It sounds incredibly official. Senior medical advocate.
Right.
You can just see it, can't you? A laminated badge, probably a clipboard, a fancy degree on the wall. But the reality is, this is a role that most of us just get thrown into with, like, zero training.
None.
Usually it happens at 2 in the morning, you're exhausted, and you're suddenly the only thing standing between someone you love and a very, very complex medical system.
It's the job nobody applies for, but it is hands down the most important role you will ever play, and the stakes, they just couldn't be higher.
It really feels like being thrown into the deep end. And for this deep dive, we're looking at a very specific and honestly a pretty terrifying scenario to help us learn how to swim. We're unpacking a case study of a 75-year-old woman. She's COVID-19 positive. She's dealing with what doctors are calling excessive diarrhea. And there's a concern about something called silent pneumonia.
It's a really complex case, but it's also a perfect teaching moment because if you just look at her chart, on paper, she looks like she's being treated perfectly.
Right, all the boxes are checked.
All the boxes, prescriptions, a diagnosis. But when you actually zoom in on the cocktail of drugs she's on, Paxlovid, amoxiclav, fluconazole, and Reglan, you realize the treatment plan itself might be the most immediate danger.
That's a hard concept to wrap your head around. We're all conditioned to trust the prescription pad.
Of course.
If a doctor writes it, you take it. But it sounds like today is less about adding medicine and more of a masterclass in something you call deprescribing.
That is the word of the day, deprescribing. It's about having the confidence to question assumptions and to spot the difference between treating a virus and just chasing a side effect.
So what are we covering?
We need to look at 3 critical areas. The medication storm that's just wrecking her gut, the hidden danger of silent hypoxia, and the safety checks that are required for strong antivirals.
Okay, let's start with the gut, this medication storm. I think for most healthy adults, diarrhea is just a nuisance. But for a 75-year-old woman fighting COVID, we are not just talking about an inconvenience, are we?
Absolutely not. Context is everything here. In a geriatric patient, excessive diarrhea is a life-threatening medical emergency.
Wow.
It's really just a math problem. As we age, our bodies hold less water. So if you introduce rapid fluid loss, the math just stops working very, very quickly. You get electrolyte imbalances, which leads to kidney failure, heart rhythm issues, and this is a big one, falls.
Because they get dizzy.
Dizzy, weak, confused, and a fall for a 75-year-old can be lethal. So stabilizing the gut isn't about comfort, it is 100% about survival.
Okay, so we've got this patient, she's losing fluid at a dangerous rate. Let's look at the drugs. You mentioned 4 of them. Bring it down for me. Why is this specific cocktail creating a storm?
So let's start with the antibiotic. Amoxiclav, you probably know it as Augmentin. It's a very common, very heavy-hitting antibiotic.
Okay.
But it is notorious for causing diarrhea.
I feel like I've heard that about most antibiotics, though. They kill the good bacteria in your gut, right?
That's definitely part of it, sure. It just wipes out the microbiome. But amoxiclav has a specific component called clavulinate. That's the clav part of the name. Its job is to stop bacteria from destroying the antibiotic, but it has this really nasty side effect. It acts as a gut irritant. It actually stimulates the smooth muscle in the intestines.
So wait, it's not just killing good bacteria, it's physically forcing the gut to contract.
Exactly, it's hitting the eject button. Statistically, about 1 in 3 patients on this drug, that's up to 34%, get diarrhea. In a 20-year-old, that's an annoyance for our patient.
It's catastrophic, she's losing water she just can't spare.
And that's where the cascade starts. Because what does the doctor do when they see a patient at risk of infection? They add an antifungal, just in case. So enter fluconazole.
Right, just in case she gets thrush from the antibiotic or something.
Precisely, it's prophylactic. But fluconazole is also hard on the GI tract. So now you have 2 drugs irritating the gut. But the real culprit, the one that just makes you go, what is going on here?
Yeah.
Is the Reglan.
Reglan, I know that one. It's for nausea, right? That seems logical if she's feeling sick.
It is logical if you only look at the nausea, but Reglan, the generic is metoclopramide, is a prokinetic drug.
Hold on. Prokinetic. That literally means pro-movement, doesn't it?
It does. It steps on the gas pedal of the stomach.
Yeah.
It's designed to speed up gastric emptying to stop things from coming back up.
But she already has excessive diarrhea. Why on earth would a doctor prescribe a gas pedal when the car's already careening downhill? Is that just an error?
It's not a clerical error on the chart. It's an error of context. This is what happens in siloed medicine. The doctor treated the symptom, the nausea, without looking at the whole system.
So they fix the stomach, but wreck the intestines.
You got it. You're treating a patient who is losing fluids too fast with a drug drug designed to make them lose fluids faster. It's like trying to put out a fire with gasoline. And with Reglan, specifically in the elderly, there's a black box warning we have to talk about.
That's the strongest warning the FDA gives, right? What's the risk?
For elderly patients, Reglan carries a significant risk of tardive dyskinesia.
Break that down. What does that look like?
It's involuntary movements. So, grimacing, tongue movements, rapid eye blinking, tremors in the fingers. And the scary part is, in older adults, this can become permanent even after you stop the drug.
Wow.
So you have a medication that is worsening the primary threat dehydration and carrying a risk of permanent neurological damage.
And then, on top of all of that, she's on Paxlovid for the COVID, which is famous for causing
Paxlovid poop. It's a very, very common side effect. So you have 4 distinct medications, all pushing the body towards severe diarrhea.
That is the definition of a perfect storm. So if I'm the advocate, if I'm her daughter or son standing there, what do? I can't just throw the pills away.
No, you don't go rogue. You advocate. You start the conversation about deprescribing. The goal is just to strip this regimen down to what is strictly necessary. You need a script.
Okay, give me the script. I'm on the phone with the doctor. What am I saying?
You ask very specifically, given her excessive diarrhea, can we pause the Reglan immediately? That's the low-hanging fruit. It's actively working against her.
Okay.
Then you ask, is it strictly necessary to continue the amoxiclav and fluconazole if bacterial pneumonia hasn't been confirmed?
Is it strictly necessary? That's a powerful phrase. It forces the medical team to stop autopilot and really justify the risk.
Exactly. And that leads us right into our second big danger zone here. Why is she even on the antibiotic in the first place?
Right. She has COVID. COVID's a virus. Amoxiclav's an antibiotic. I mean, my high school biology is rusty, but antibiotics don't kill viruses, so why is she taking it?
It's not confusion, it's fear. This is a classic trap in treating respiratory illness in seniors. There's a feel of a secondary bacterial infection. The worry is that while the virus is beating up the lungs, bacteria might sneak in and start a second fire.
But isn't it just safer to take it? You know, the whole better safe than sorry argument.
In a healthy 20-year-old?
Yeah.
Maybe. You get a stomachache? In a 75-year-old with severe diarrhea? No. Better safe than sorry doesn't apply when the safe option is causing dehydration that could kill her.
So the side effect is a clear and present danger.
Right. And the benefit killing an infection that might not even exist is hypothetical.
So how do we stop guessing? How do we find out if she actually needs it?
You have to close the diagnostic gap. You need 2 things, a chest x-ray and pulse oximetry.
Okay, let's talk about the oxygen part first. We mentioned silent pneumonia in the intro. That sounds like a horror movie title. What is it?
It's a phenomenon we saw a lot in the early days of the pandemic, especially in older adults. It's also called happy hypoxia. Basically, the oxygen levels in the blood can drop to dangerously low levels, but the patient isn't gasping for air.
They don't feel short of breath.
They don't. They aren't clutching their chest. They might just seem a little confused or tired.
That is terrifying, because usually if I can't breathe, my body screams at me, my heart races. Why doesn't that happen here?
It's because of how our body's alarm system works. Usually the brain panics when carbon dioxide builds up, not just when oxygen drops. We breathe to clear out CO2.
Okay.
In COVID patients, the lungs get stiff and inflamed, which prevents oxygen from getting in, but, and this is the key, they can often still push carbon dioxide out.
So the exhaust pipe is working fine, so the alarm doesn't ring, but the intake is broken.
That's a perfect analogy.
Yeah.
The brain thinks everything's fine because CO2 levels are normal. Meanwhile, the body's cells are starving for oxygen.
Wild. So you can't rely on them telling you, I can't breathe. You need the data.
You need the pulse oximeter. You need the number. But back to the antibiotics, you also need that x-ray. Because viral pneumonia just looks different than bacterial pneumonia on a scan.
How so?
Viral pneumonia, like from COVID, usually shows up as that ground glass look. It's hazy, it's patchy, usually in both lungs. Bacterial pneumonia often shows up as consolidation, a solid white patch in one specific area.
I see.
So if the x-ray shows viral patterns and the blood work isn't showing a massive spike in white blood cells, then that amoxiclav is likely all risk and no reward.
So the advocacy question is, can we confirm she actually has a bacterial infection via x-ray before we continue these antibiotics that are causing dehydration?
You nailed it. You are asking for confirmation before medication. That is the essence of being a medical advocate.
Okay, so we've paused the gut-wrecking drugs, we've checked the x-ray, but we still have the COVID to deal with. She's 75. We do want to treat the virus itself.
We do. The virus is still the enemy. But we have to do a safety check on the heavy artillery. We talked about Paxlovid causing diarrhea, but there's a bigger sort of hidden issue with it that people forget. Interactions. Massive interactions. See, Paxlovid isn't one drug, it's a combination. It contains a drug called ritonavir. Ritonavir's job is to shut down an enzyme in your liver called CYP3A4.
Okay, let's simplify that. CYP3A4. What does it do?
Think of it as your liver's garbage disposal unit. Its job is to break down drugs and flush them out so they don't build up to toxic levels.
And Paxlovid deliberately jams the garbage disposal. Why?
Because it wants the main antiviral medication to stay in your body longer to fight the virus. If the disposal is working normally, it flushes the cure out too fast, so it jams the mechanism to keep the levels high.
Okay, that sounds smart for fighting COVID, but I'm guessing it's really bad if you're taking other drugs that rely on that same garbage disposal.
Exactly. If you're on statins for cholesterol or blood thinners like rivaroxaban or heart rhythm meds, and you jam that disposal, those drugs have nowhere to go. They just build up. You could overdose on your daily heart medication just by taking your normal dose.
That's incredibly dangerous. And a 75-year-old is almost guaranteed to be on at least one of those meds.
It's highly, highly likely. So the question becomes, if Paxlovid is too risky, either from interactions or just the GI side effects, what else can we do?
Are there alternatives? Or are we just stuck?
Oh, there are valid alternatives. The best one in this specific case might be remdesivir.
I remember that name. That's the IV one, isn't it?
It is. It's a 3-day outpatient IV treatment. Now, getting an IV sounds like a hassle compared to a pill, but think about the benefits here. It goes straight into the bloodstream.
So it bypasses the stomach completely.
Right. 0 diarrhea side effects. And crucial for our patient, it doesn't have those massive liver interactions. It doesn't jam the garbage disposal.
So for this specific patient with the gut issues, on multiple other meds, the IV route might actually be the safer, smoother road.
It often is. There's also molnupiravir, which is another pill, though it's generally considered a bit less effective. But as an advocate, you just need to know these options exist.
So the question for the doctor or pharmacist is, have we cross-referenced all her maintenance meds with Paxlovid? And given the GI issues, is she a candidate for remdesivir?
Yes. Ask for a formal interaction check. Don't just assume the computer caught it. Ask a human pharmacist to actually look at the list.
Okay, we've navigated the prescriptions. Now we're back home. We're the boots on the ground. What are we watching for? When do we hit the panic button and call 911?
You need a clear set of red flags. These are non-negotiable. Number 1, confusion.
Sudden disorientation, like she doesn't know who you are.
Exactly. Or where she is, or she's just talking nonsense. That is not just being old. That is a sign of severe dehydration, or that hypoxia we talked about. The brain isn't getting the fuel.
Okay, and physically.
A blue tint to the lips or nails. That's cyanosis. That means oxygen is critically low, and you watch the pulse oximeter. If it drops below 92%, or it drops rapidly from where it was an hour ago, that's an emergency.
And on the hydration front.
No urination for 8 hours. That means the kidneys are shutting down to save water. That is a medical emergency.
Speaking of hydration, this is something I think a lot of us get wrong. We think, she's dehydrated, let's give her a big glass of water.
And that is a huge mistake. When you have diarrhea, you're losing salt electrolytes along with the water. If you replace that with just plain water, you dilute the remaining salts in your body even further.
Which can cause seizures, right?
Yes, it's really dangerous. So water can actually make things worse. You need salt and sugar. Pedialyte is the gold standard. Oral rehydration solutions. Or even just salty broth.
So what is electrolytes? What about the how?
This is maybe the most practical tip I can give anyone. Do not let her gulp it.
Oh, that's the hardest part to manage. If I'm thirsty, I want to chug a whole glass. You're saying I have to be the bad guy.
You do, and here's why. When you dump a large volume of liquid into the stomach, it stretches the stomach wall really fast.
Okay.
That stretch sends an immediate electrical signal down the line to the colon that basically says, incoming, make room.
And make room means?
Immediate diarrhea. It's called the gastrocolic reflex. You're trying to hydrate them, but by letting them gulp, you are mechanically triggering the body to flush fluids out even faster.
Incredible. So slow and steady wins the race.
The strategy is low and slow, small sips, maybe 2 to 4 ounces every 15 minutes. It's tedious. You have to sit there with the timer, but it works.
That is such a practical tip. Sip, don't gulp.
Now,
What about food? The old advice was always the brat diet. Bananas, rice, applesauce, toast. Is that still the go-to?
it's outdated for seniors. It's just too restrictive. I mean, think about it. It's almost all carbs. A 75-year-old fighting a virus needs protein to maintain muscle mass. The brat diet is basically starvation mode.
So what's the upgrade?
The expanded bland diet. You want gentle proteins. Boiled chicken, scrambled eggs, tofu. Things that are soft and boring but have nutritional value. And you avoid the triggers. No dairy, except maybe yogurt. No grease, no spices, and no caffeine.
You mentioned yogurt. Let's talk about probiotics. Are they actually useful here?
In this specific case, with antibiotics involved, they can be very useful, but you have to pick the right one.
Not all bacteria are created equal.
Exactly. Most probiotics are bacteria, lactobacillus, and so on. If you take those while you're on amoxiclav, what happens?
The antibiotic just kills them.
Right. It's friendly fire. You're swallowing expensive bacteria just to have the antibiotic destroy them.
So what's the workaround?
You need a probiotic that isn't a bacteria. You need a yeast. Yes. Specifically, Saccharomyces boulardii. Because it's a yeast, the antibiotic ignores it. It survives the journey, sets up shop in the gut, and can help fight off the bad stuff like C. diff.
Saccharomyces boulardii, that's a mouthful.
It is, but it's the heavy lifter for antibiotic-associated diarrhea. Lactobacillus rhamnosus GG is another good one for the recovery phase. But Saccharomyces is what you want during treatment.
Any risks?
There is nuance. For severely immunocompromised patients, it can be a risk. So the rule remains, always ask the doctor first. Is Saccharomyces safe for her?
This has been, honestly, incredibly empowering. It feels like we've taken this chaotic, scary situation and given it a structure.
That's the whole goal. When you're in the crisis, you feel helpless, but you aren't.
So let's recap the 3 pillars. Pillar 1.
Stop the medication storm. Ask to pause the Reglan immediately. Ask to deprescribe the antibiotic if it's not confirmed to be necessary.
Pillar 2.
Confirm the diagnosis. Get the x-ray. Check the pulse ox. Don't treat a viral ghost with a bacterial weapon.
And pillar 3.
The antiviral safety check. If you use Paxlovid, triple check those interactions. Or ask about switching to IV Remdesivir to save the gut and avoid the problem entirely.
You know, what strikes me about all this is how afraid people are to ask these questions. They don't want to be difficult.
I hear that all the time. But you have to reframe it. You aren't being difficult, you're being the safety net. The lung doctor is looking at the lungs, the infectious disease doctor is looking at the virus. Who is looking at the whole patient?
You are.
You are. The caregiver is the only one seeing the whole picture. Asking, can we pause the Reglan, isn't challenging authority. It's helping them treat the human being in front of them.
It's information is medicine. In a case like this, asking the right question can be just as life-saving as the right pill.
Absolutely. Sometimes the most effective medical intervention is simply pressing pause.
And here's a thought to leave you with. We talked about silent hypoxia, the body failing to signal that it's running out of air. It makes you wonder, what other signals are we missing? Because we're expecting the classic symptoms. In medicine and in life, sometimes the loudest dangers are the ones that don't make a sound at all.
Always look a little deeper.
Thanks for diving in with us. Stay curious.